Hello, my name's John. I'll be your nursing instructor today. How are you doing? Good to hear. I am too. Today, I'd like to talk to you about the anatomy of a central venous catheter. I'm excited. I made you a page. This is what we'll be talking about today, the anatomy of a central venous catheter. But first, let's get situated. Let's get nice and comfortable. Put on my stethoscope, and I'll see you in a little bit. Well, I'm glad you're here, and I think your patients will be too. A quick introduction before we get started. My name is John. I've been at the bedside for 12 years now, 10 in the ICU. I'm also a nurse educator and a practicing artist for over 25 years. And today, we're going to do a full anatomy breakdown of the triple-lumen central venous catheter, from luer locks at the top all the way down to the tip sitting at the cavoatrial junction. By the end of this video, you'll be able to look at a central line and actually understand what you're looking at. Not just recite it, but visualize it. Let's get into it. Before we break down the anatomy piece by piece, let's answer the foundational question. Why the heck does this thing exist? A peripheral IV, your standard 18 gauge in the antecubital, works great for a lot of things. Fluids, antibiotics, a blood draw here and there. But the ICU doesn't deal in simple. Your ICU patient might need vasopressors running simultaneously with TPN while you're also drawing labs and monitoring central venous pressure. A peripheral IV cannot do that job. Enter the central venous catheter, or CVC, also called a central line. This is a large bore catheter that gets placed by physicians or advanced practice providers, trained to do so, into one of the central veins. Most commonly, that's the internal jugular vein in the neck. You'll also see subclavian placements, and if those aren't accessible, the femoral vein in the groin. Yes, I say femoral, not femoral. Fight me in the comments. So we have the femoral vein. We try to avoid that one. More bacteria, more infection risk. Nobody wants a femoral line if they can help it. The catheter threads through that vein and the tip lands at the cavoatrial junction, right where the superior vena cava meets the right atrium. That's prime real estate. High blood flow, rapid dilution of medications, direct access to central circulation. Now, the specific type we're breaking down today is the triple-lumen CVC. 3 independent channels, 3 separate ports, and that independence is the whole point. Stay with me. All right, we're going top to bottom. At the very top of each lumen, you've got your luer locks. These are threaded connection points, the interface between your IV tubing, your syringes, your caps, and the catheter itself. There are 3 of them, 1 for each lumen, and they are color-coded. White, proximal lumen, blue, medial lumen, and brown, distal lumen. We're going to come back to see what those colors mean in a minute, but burn those colors into your brain right now. White, blue, brown. There's a mnemonic I use. White clouds, blue ocean, brown in the ground. And we'll unpack that when we get into the internal anatomy. So just below the luer locks, each tube has a clamp. Simple slide clamp. Open it, flow goes through. Close it, flow stops. This sounds very obvious, but I will tell you from 12 years at the bedside, when a line isn't flushing and you're troubleshooting at 3 a.m., the first thing you check is whether the clamp is open. I've done it. You'll do it. Check the clamp first. Always. Moving down, the 3 tubes converge at the hub. This is the central body of the catheter, where everything comes together before entering the single tube that goes into the patient. Attached to the hub are the suture wings. Those little flat tabs on either side, these are what get sutured to the patient's skin to hold the catheter in place. Without them, you've got a central line that can migrate. That's not a situation you want. And right below the hub, sitting against the skin, is the CHG disc, also called a biopatch or chlorhexidine disc. This little disc is doing serious work. Chlorhexidine is an antimicrobial agent, and this disc sits right at the insertion site to create a barrier against bacteria. It's one of the primary defenses against CLABSIs, or central line associated bloodstream infections. CLABSIs are not minor. We're talking upwards of $20,000 to $40,000 per infection. So That can extend ICU stays, increase mortality risk. That disc, it really matters, so you got to respect it. Below the CHG disc, you've got the tube itself, the single catheter body that threads through the vein. This is where the 3 internal lumens run in parallel, staggered, all the way down to the tip. And at the very end, the tip, this is where the magic happens. The tip sits at the cavoatrial junction, the junction of the superior vena cava and the right atrium. Here's why placement matters. If the tip migrates too far into the right atrium, it can irritate the SA node, your heart's natural pacemaker. That irritation can trigger arrhythmias. So tip position gets confirmed on chest x-ray after every central line placement, every single time, non-negotiable. So now we go inside. This is where the triple-lumen CVC gets genuinely interesting. Look at the cross-section in the illustration. Inside that tube, there are 3 completely independent channels, 3 lumens running the length of the catheter. They don't communicate with each other. They don't mix. Each one has its own entry point at the hub and its own exit point along the tube. And here's the key. Those exit points are staggered. The white lumen exits first, closest to the hub, highest up on the catheter. That's why it's called the proximal lumen. White clouds, the proximal lumen is at the top, like clouds in the sky. What goes through the proximal lumen? You could do fluids, blood products, IV medications, blood sampling. It's your workhorse port. High flow, versatile, and accessible. The blue lumen exits in the middle. Medial lumen. Blue ocean, the middle layer, between the clouds above and the ground below. The medial lumen is commonly used for TPN, or I always mess this one up, parenteral nutrition, and additional IV medications. TPN is caustic to peripheral veins, which is one of the reasons central access exists in the first place. The high blood flow at the cavoatrial junction dilutes it rapidly. Finally, the brown lumen exits last, at the very tip of the catheter, distal lumen, brown in the ground, the bottom layer. And here's the memory hook I've used for years. Brown is the color of dirt, and if your patient has a central line, they're probably in deep, they're sick. The distal lumen is at the deepest point. The distal lumen is used for CVP monitoring, or central venous pressure, as well as blood products and IV medications. Because it sits at the cavoatrial junction, it gives you the most accurate hemodynamic readings for CVP. So why the staggered design matters? Here's the clinical payoff of everything we just covered. Each lumen is independent. That means you can run 3 different infusions simultaneously through one catheter, and they won't mix until they're well downstream in the bloodstream, where rapid dilution occurs. Why does this matter? Because some medications are incompatible. You cannot run them through the same line at the same time, like Lasix and Versed, or heparin and Protonix, or Levophed and sodium bicarb. Put those together in the same lumen and you got a chemical reaction, precipitation, and potential harm to your patient. The staggered design of the triple-lumen CVC solves that problem. 3 independent channels, 3 separate exit points, simultaneous infusions, blood draws, and hemodynamic monitoring, all through one catheter. That's elegant engineering. And now you understand why it's designed that way, not just that's the way it is. So let's bring this out of the illustration and into the real world. Say you're taking care of a fresh admit from the ED, septic shock. They just came up with a triple-lumen CVC in the right internal jugular, and here's how you're going to think about that line. Proximal, white. You've got fluids running, maybe a blood transfusion queued up. This is your high-volume port. Medial, blue. An antibiotic is ordered. Pharmacy is sending it up. This port is reserved. And distal, brown, your vasopressor, Levophed, is running here. You could use the brown distal port to get your CVP if no fluids are running on this lumen as well. So you got 3 lumens, 3 jobs, 1 catheter. Now, a few things to keep in your head every time you're working with a central line. Number 1, confirm the tip position. Before you use a freshly placed central line, you need that chest x-ray read. Tip at the cavoatrial junction, not in the right atrium, not in a branch vessel. You need it confirmed. Number 2, maintain sterility. Every time you access a lumen, every cap change, every blood draw, every tubing connection, you're creating an opportunity for bacteria to enter. So scrub the hub every time, no exceptions. Every time I scrub the hub, I sing the happy birthday song to my patient, sometimes silently, but they get a kick out of it. Number 3, assess the site. The CHG disc is doing its job, but it's not magic. You're looking at the insertion site every shift. Redness, swelling, drainage, tenderness, any of those findings get documented and reported. Number 4, know your incompatibilities. You don't have to memorize every drug interaction in existence, but you need to know the common ones in your unit, and you need to know how to look them up fast when you're not sure. And number 5, check the clamps. I said it before, I'll say it again. If a line isn't flushing, check the clamp before you do anything else. You'll thank me. And I've done it so many times and kicked myself so many times. Again, you'll thank me. Okay, let's cement the color coding one more time because this is the thing you'll use every shift. Picture a landscape. At the top, white clouds. That's your proximal lumen, white, closest to the hub. Fluids, blood products, blood draws. In the middle, blue ocean. That's your medial lumen. Blue, middle exit point, TPN, IV meds. At the bottom, brown in the ground. That's your distal lumen, brown, tip of the catheter, CVP monitoring, vasopressors, blood products. White clouds, blue ocean, brown in the ground, proximal, medial, distal. You'll never mix those up again. Well, that's the anatomy of a central venous catheter, from the luer locks at the top to the tip at the cavoatrial junction. That's a fun word to say. Cavoatrial junction. So every component, every lumen, every clinical reason, it's designed the way it is. If this is the kind of content that actually helps you at the bedside, visual, clinical, built for the ICU, then subscribe. We do this for every major critical care concept. Central lines, hemodynamics, ventilator management, drips, all of it, illustrated and explained the way it should have been taught in nursing school. And if you want to go even deeper on central lines, placement, troubleshooting, complications, CVP interpretation, we have the Central Command Field Guide over at rnartline.com. It's 54 pages, fully illustrated. It was written by some ICU nurse who's kind of a badass, has been at the bedside for 12 years and has been in the ICU for 10. He's kind of an artist, and I don't know, he's cool. So link is in the description. Go check it out. Again, my name is John. I'll see you in the next one.